We're going to check active range of motion in the shoulder, looking at quantity of the range of motion, quality, if you notice any aberrant movements, any reproduction of the pain. First thing we'll check is flexion. We're going to have him raise his arm up. Looking at both quantity of motion from the shoulder joint as well as from the shoulder blade, and then back down. Okay, good. If that movement was painful, we can use the scapular assist test to tease out if it's a mobility versus stability component. So I'm going to apply a posterior tilt of the scapula as well as protraction of the shoulder blade. And if that improves the range of motion or decreases his pain by a score of 2 points, that would indicate that we have some motor control or stability components across the shoulder blade that we would work on. If there was no change in the range of motion, it's probably more of a mobility component. Second motion you want to check is abduction. Thinking about scapulohumeral rhythm. And back down, try a couple more times. And that contribution from the shoulder as well as from the scapula. If we notice any dyskinesis or elevation of the shoulder blade, we can also use the scapular assist test. But this time we're going to apply a posterior tilt with upward rotation of the scapula. So my hand will be at the inferior angle of the scapula and back down. And using that force couple between my right and left hands to produce a posterior tilt and upward rotation. Again, looking for a change in pain score or a change in the quantity of the motion. It would indicate there's more of a stability component versus that mobility component. And back down. The other motions that we want to tease out in the shoulder in the active range is external rotation or hand behind the head. And we're going to have the patient reach down as far as they can, using the middle digit to come down to the spinous process and noting that from side to side. Okay. Looking for any gross changes or reproduction of that patient's pain. We're also going to bring the hand behind the back. Same thing, looking at the middle digit with the spinous process from side to side. Good. Other key motions of the shoulder blade would be horizontal adduction, especially screening for the AC joint. If we have the patient reach across their body, looking for pain reproduction, again, most commonly with an AC joint pathology or injury, and then back down, and then rest.